For those joining us, it's just 9 minutes past 8 p.m. in Melbourne. I'm so excited about this session this morning. So this morning for Dr. Zaid and evening for us in Australia. My name is Agnes. I'm the founder and the executive director of Australian Sickle Cell Advocacy. I'm a registered nurse by profession and a mother of 4. And our youngest child was diagnosed with sickle cell anemia about 11 years ago. This year should be 12. So that's how I found myself advocating for sickle cell. So our topic today is something that's very interesting to most of the people, and I just can't wait for this to start. But before we start, we are so delighted to have Dr. Ahmar Zaidi. Dr. Zaidi is a passionate doctor that I've seen on social media, and I just had to connect with him. So we are here today because early this year, we had a plan about Australian sickle cell advocacy. We were going to hold 4 main events in the community to continue raising awareness about sickle cell in Australia. But all our plans could not be realized due to COVID-19, as we know, and that has affected almost everyone in the world, and our hearts go to the people who are directly affected. So we came up with this idea of doing these sessions. We thought it was a one-off, but we think it's a good way of communicating or connecting with our members. And this is why we're doing this today. So today's topic is very powerful. We are going to hear Dr. Zaid present on the current therapeutic landscape of sickle cell disease. So I will start off by introducing my guests. As I've said, Dr. Zaid. And we've got co-hosts to Isabel, Dr. Shao, and Natalie, who are going to introduce themselves further on. And so what I'll do quickly before I give you a bio for Dr. Zaid, this is all about Australian sickle cell advocacy. So what we like doing, in case you're watching us for the first time today, we always want to tell you about our journey, why we are here today. So I'll just quickly do a presentation about our organization, and we'll dive into why we've got Dr. Zaid today. So I'm just sharing my screen, and I'll quickly do a presentation. Can we see that PowerPoint? Yeah.
Yep.
All right. Yep. So me and Natalie and Dr. Actually, all of us on this panel today, and of course our guest is passionate about sickle cell. We are part of Australian Sickle Cell Advocacy, and as I said, I'm the founder and executive director. I'm an RN. So why am I doing this? I'll just quickly do slideshow. It's better if I do that. Okay. So about me, as I said, I'm a mother of 4. Our daughter was diagnosed for sickle cell at 14 months old. During the time that I was pregnant with her, and I tell this story over and over again until one day I'll find an answer why I was in hospital for 8 weeks, almost died. 2 weeks I was in ICU. Out of all that time, my symptoms were very similar to a sickle cell crisis, and I only knew this when I went to a nursing school. And for us to find a better treatment option for our daughter, we had to make very drastic changes, or had to do something out of this world. We moved 3 states from Western Australia to New South Wales to Melbourne, where we are now. I had to change my career from business to nursing just to understand the hospital system, because I had not known, because our life changed in late 2000s. Going in hospital, I just needed to know what our daughter was going through. And out of that came Australian Sickle Cell Advocacy. It's a long journey how we ended up doing this, but we came with other mothers who are interested about advocating for rare diseases. One of them was Natalie, and my husband and a few friends. We started the Australian Sickle Cell Advocacy. And with our daughter, as we have spoken about this before, she's went through all the treatment options that is on the books until finally she had a bone marrow transplant last year. On 21st Feb 2019, she's just over 470, I think today 77 days post bone marrow transplant. And so who we are a leading patient sickle cell advocacy organization in Australia. We are a registered charity with branches across Australia. The initiative started off in 2014 and we formally registered just about 2 years ago, supporting people in all states in Australia, and we've got a lot of followers on social media and people that we send our newsletter to. We are governed by a board of directors, and Dr. Vaughan is one of them. She's a scientific advisor. Our head is Dr. Margarita Evans-Scalia, AM. She's the interim chairperson at the moment. So together with Natalie, myself, and Preston, we are part of the board as well as the executive team, where we manage the executive and the committee members. We've got chapters in New South Wales, Western Australia, and South Australia and other states are coming up, and we've got representatives in all the states. And our mission, we are here as a leading advocacy group for people affected by sickle cell disease in Australia. Our values, excellence, perseverance, integrity, and caring. We care about these values because there's a history behind why we did this. And one day I think we just have a session explaining why we have these values, but I don't want us to take too much time. Our objectives, they are divided into 4 categories. We are a very young organization. At the moment, we are focusing on raising awareness about sickle cell disease in Australia. We provide education and information and support people affected. We started the first ever support group meetings for sickle cell people in Australia last year, and our last one was March this year, but unfortunately we couldn't do any, and that's why we're doing this. We are advocating for more scientific research. We realize there's so many questions. We had a scientist on the show the other day, and there's so many questions from participants and the caregivers, even the patients themselves. So we are advocating for more to be done in this area. And that's just us in the community. You see that that was our first support group meeting, and we've been raising awareness in the community. We had a very successful launch. That's one of the pictures. We did a poster presentation at ASCA, and yeah, so that's just us. Partnership is one of the things that we value. I think in this business, you need to partner with other organizations because we are all fighting the same cause, and we've partnered with a lot of organizations. One of them that we've partnered with is Australian Primary Health Care Nurses Network, which is APNA, and we've done a sickle cell course with them, which is actually launching on the 19th. We did a course just to as another way of raising awareness about sickle cell. So we are offering that course to nurses, student nurses, doctors, and student doctors, and whoever wants to learn about sickle cell. We'll be doing more courses to tell our different communities, but at the moment this course is out and we're excited about that. So that's the course. Initially we wanted to give out 4 courses, so you see the flyer, but we said this is, we need to give out more. And the reason why I'm saying we give 8 courses is because we've partnered with an organization that has members as nurses. They're offering the course to the nurses, their nurses, the members, free of charge. But for us, the partnership was purely us giving them the course and nothing else. No money, nothing was received. We just did the course. And for non-members, they'll be paying about, I think, $38. So we went and said, give us some courses to give for free, and that's what they've done. So the course will be launched on the 19th. And we've posted on social media how you can go hold of them, the course. So get in touch and we can give you a course, test the course for us and give us feedback if there's anything to change. And again, I show this slide over and over again. Why are we doing this? For us, we feel it's been put upon us to raise awareness about sickle cell disease in Australia. We looked at, when we did the ASCA presentation in London last year, we looked at this article by Kato, ETL, L 2018. You see that these countries that are labeled in different colors, apart from the green colors, there's genetically, when you come from this part of the world, it's just the way it is. You are at risk of having the sickle cell trait. We did that, then we went to the census since 1996 to 2018. Then we looked at the people that have migrated from those countries to Australia. Again, I want to emphasize that there's nothing wrong to talk about migration. It's part of us, and these are the difficult situations, especially in this day and age, to talk about. There's nothing wrong about having a genetic disease, and there's nothing wrong to raise awareness about the genetic disease. So this is why we're doing this, emphasizing that people that come from this, they might be at risk of having the sickle cell trait, and you can only know if you do the test, and that's why we're here today. And then finally, this is very important for us. I would just want to emphasize that when Dr. Zaidi will be doing a presentation, He'll be doing a presentation based on his work, and some of us may share our stories, but that's purely it. And he won't be giving medical advice. If you've got any specific medical condition or you've got any specific questions, please consult your GP or hematologist. If you don't have a GP or hematologist, you'll be able to contact us, then we'll be able to connect you with one in your area. And that's the end of my presentation. I won't take too much time. I will just like now to introduce you to our host today. And we are very honored today to have Dr. Zaid. So Dr. Zaid is the classic hematologist who cares for chronic and acquired hemolytic anemias and hemoglobinopathies, primary sickle cell disease. His research interests are focused on the intersection of technology and disease, as well as on the healthcare outcomes and novel biomarker development. He is also a tireless advocate for sickle cell disease. I can attest to that. And family believes the advocacy and patient education can be achieved using social media as a tool to interact with patients and physicians. So now it is my pleasure to introduce to you our host today. As I said, we have my co-host Natalie, Isabel, and Shao. They are going to further introduce themselves, but we are here today because of Dr. Zaid, and I will hand over the seat to Dr. Zaid. Take it off from here. Thank you so much.
Thank you so much, Agnes. I really appreciate that. And I'm going to go ahead and, oh, it's not letting me share my screen with the party at this point. Can we?
It's not letting you?
No, it's saying host has disabled screen sharing.
Oh.
So while we're working on that, I can tell you guys that you know, sickle cell disease has been something that I got interested in because I went to medical school in the West Indies, and while there I got to see sickle cell disease as it looks in a developing country, and I got to see physicians treating sickle cell disease without the resources to treat it. And then I got to come here in the United States where I got to see sickle cell disease patients being treated in a high resource setting with no compassion. Very different from the experience that I saw in the West Indies. And that was very striking to me. And that got me involved in this space. Now, I'm not gonna talk too much about all of that. We have quite a bit of information to cover today because the therapeutic landscape, thankfully, for sickle cell disease is exploding. It's evolving quickly, and there's a lot of information to keep up on, keep track of. And my efforts on social media have been geared actually towards my patients, because 30 minutes, 20 minutes, 30 minutes with a patient in the clinic is not enough to go over conceptual basics of sickle cell disease pathology, physiology, and to talk about the way new drugs work. So I was finding that if I spent the appropriate amount of time, I would run out of time with my patient. So now I made a podcast, I made an Instagram, I made a Twitter. So if I want to start a patient on a new therapy, I tell them, hey, why don't you go listen to my podcast, episode number 5. This is the therapy I'm thinking of starting, and tell me what you think once you listen to it. Then they get an hour of information. Anyways, we'll give you guys a high level sort of view of what's happening in the therapeutic landscape of sickle cell disease. Here are my disclosures. So we'll briefly talk about sickle cell disease, and then we'll talk about Endari, Adakveo, Oxbryta. It says overview of gene therapy here, but for purposes of this talk, I'm going to exclude gene therapy at this moment. So of course, we all understand why this is such an important topic. We all understand that for the last 30 years, we have only had hydroxyurea in the toolbox for physicians that are taking care of sickle cell disease. And of course, as great as hydroxyurea is, sometimes when the only tool you have is a hammer, every problem looks like a nail. There are a significant amount of patients with sickle cell disease that are not candidates for hydroxyurea simply because of the genotype they have. That's the first thing. The second thing is there are a lot of medical and social issues associated with hydroxyurea that all of us are very well aware of, that sometimes make it not practical for patients to be taking hydroxyurea even when they are candidates to do so. So we've been waiting for a long time to have the ability to walk into a clinic room and say, here are your options for therapy. Let's talk about your options and why each one is different, why each one is, what are the pros and cons. This has been a long time coming. So the story from 1910 to 2020 is a very interesting one. Of course, in 1910, Walter Clement Noel is described as the first American patient with sickle cell disease by James Herrick. And then we get a better understanding around how sickle cell disease happens, what the mutation is by people like Lemuel Diggs and Linus Pauling and Vernon Ingram. Of course, right here in Detroit, Dr. Charles Whitten starts talking about the psychosocial issues involved with sickle cell disease and how this is a biopsychosocial disease. The Black Panthers, sort of civil rights activist group, funds the first sickle cell disease screening in the United States in the 1970s, and the National Sickle Cell Disease Act is passed. Of course, in the 1980s, we have the PROPS study that looked at penicillin prophylaxis to prevent infection in individuals with sickle cell disease in the 1980s. Of course, hydroxyurea shows itself around the 90s after animal studies in the 80s. Then we see Endari almost 20 years later, followed by Adakveo, and then voxelotor in the November to Remember, as it's been called. So this is where we are right now. But it has taken us a very long time, and it has been a very hard path to this point in time. And of course, sickle cell disease is two stories, right? As Agnes sort of pointed out, it's a story of 5% and 95%. So we are fortunate in the United States and Australia to be part of that 5%. But really, this is a story of that 95% who might never see this new therapeutic landscape. And I think it's always important to keep that frame of reference in mind, that while we take care of our 5% right now, the end goal is that the entire population of sickle cell disease, the 5% population and that 95% population, both get treated, both get to the finish line with equity and equality along with this evolving therapeutic landscape. And we always talk about sickle cell disease as sort of an umbrella term. So of course, when we say sickle cell anemia, we're talking about hemoglobin SS or hemoglobin S beta 0. But when we say sickle cell disease, we're also including other compound heterozygote phenotypes like hemoglobin SC, S beta plus, SO, SD. So this differentiation will become important because, as you all know, hydroxyurea is indicated at the age of 9 months in people with sickle cell anemia. That's SS and S beta 0. So now we're suddenly in a therapeutic landscape where these other compound heterozygote types will be able to access new medications. And as you all know, as a quick review, this is an autosomal recessive disease. That means that both parents must pass on a gene to their child. And in the case where there are two parents that have trait, you have a 25% chance of having an affected child. So of course, the spirit of the red blood cell is such that it is completely dependent on its ability to be deformable and maintain its disc shape. And inside of each red blood cell is a molecule called hemoglobin. And that molecule is so important, it's quite literally the reason why we breathe, to load hemoglobin with oxygen. What we see in sickle cell disease is that a defective beta globin gene introduces sort of a sticky pocket within hemoglobin. And the exposure of that sticky pocket only comes when oxygen is not attached to hemoglobin. And what we see then is that these hemoglobin pieces start sticking together, forming these long, sort of rigid strings that alter the shape of the red blood cell and alter the spirit of the red blood cell. And of course, within each individual red blood cell, there are trillions of hemoglobin molecules. So in the body, you have as much hemoglobin as you do grains of sand on every beach on planet Earth. And with that being said, of course, a disease that affects hemoglobin will have multiple manifestations, which we have all seen. So let's go through this in sort of a little bit of a pictorial fashion. I like pictures better than words. So we have red blood cells. When oxygen comes off of them, their shape changes, they sickle. And what we see is damage to the blood vessel surrounding it, oxidative damage. And the result of that then being the generation of what we call sticky proteins, or like Velcro almost on the blood vessels. And this is, usually by proteins called selectins. And then we see this activation of the immune system, particularly neutrophils. And then of course that traffic jam at the end of it that we're all so familiar with, right? The traffic jam of vaso-occlusion that results in pain and organ damage and stroke and all of the manifestations of sickle cell disease, both acute and chronic. And of course, the acute complications are the things that keep patients in touch with the hospital, but it's the chronic complications that keep physicians like me awake at night thinking about my patients, right? It's the chronic complications that result in a mortality that's 30 years less, in a sort of expected survival that's 30 years less than non-sickle patients. So the management of sickle cell disease is complicated, right? It's a multi-system condition that's characterized by acute and chronic complications. Early diagnosis has definitely improved life expectancy, but the quality of life we still find deteriorates. And there are psychosocial reasons for that on top of the biologic reasons for that. And those psychosocial reasons are very underappreciated. So today we're going to be talking about the biologic sort of changes we can make, but the psychosocial issues we need to still keep in mind. The anxiety, the anxiety associated with when is my next pain crisis coming, the PTSD associated with that really bad pain crisis that lands you in a hospital with a physician or a nurse that doesn't believe you, right? These types of psychosocial issues really change the way your disease plays out over your life. So even with the best care possible, life expectancy compared to the normal population can still be reduced by almost 30 years. And the bottom line is we have failed the adult sickle cell population. We have seen a tremendous decrease in the deaths of children with sickle cell disease, but as time has gone on, actually, the amount of deaths we're seeing with adults with sickle cell disease has increased. So we definitely, at least in the United States, have a huge problem with adult care for sickle cell disease. I'll be curious to hear what's happening in Australia from that standpoint. So there's two ways we can classify treatments. We can classify them as treatments that help and treatments that cure. For the purposes of this talk, we'll be talking about treatments that help. So let's start with blood transfusion. So blood transfusion, of course, is based in the concept that if I decrease the number of sickle cells by putting in normal red blood cells, I can decrease the amount of endothelial injury, the amount of damage that's happening. And the situation in which blood transfusions are used most is in the setting of stroke, both stroke prevention and stroke treatment, right? So we have two types of stroke prevention, primary and secondary. When we talk about primary stroke, we're talking about reducing the chance of a first stroke. And this is usually happening in people who have had their transcranial Doppler that shows that they might be at high risk for stroke. These patients are put on blood transfusions. Then, of course, secondary stroke means you've had a stroke and we're trying to prevent the next one, because once you've had a stroke, you're higher risk for a second stroke. And those patients with secondary prevention by blood transfusion are basically on lifelong blood transfusions from that point. Of course, it's not that simple, right? Blood transfusions are associated with adverse events too. We definitely are infusing patients with lots of iron with every blood transfusion that goes in. The body doesn't have a good way to remove that iron, so patients are required to take chelation therapy to remove that iron. Of course, with every blood transfusion you get, because the blood is not coming from someone who's identical to you, there's a chance that you have a reaction or develop an antibody to the blood that's being given to you. So we call that alloimmunization, which in the United States, at least at my center, we have about a 25% chance, 25% incidence of alloimmunization or antibodies to blood. So blood transfusions come with some pros and cons, but of course, when patients are sick, when patients are really spinning out of control into the wrong direction in the hospital, we use blood transfusions frequently, be it for stroke, acute chest syndrome, splenic sequestration, many of the sort of acute issues that you guys are familiar with. All right, let's talk about the old standard, hydroxyurea. So hydroxyurea is the old standard. It's the old standard. It's the flag bearer of sickle cell therapeutics for a good reason, right? We have vast experience with hydroxyurea. We have a medication here originally not designed for sickle cell disease, but one that is supremely effective in sickle cell disease and works in a variety of ways, not only by increasing fetal hemoglobin that you guys are so familiar with, but also by reducing the number of sickle cells in the body, by reducing the white blood cell count in the body in effort to reduce that traffic jam that we call vaso-occlusion. There's of course 30 years worth of evidence looking at the safety of this medication that makes physicians so comfortable with hydroxyurea's use, so much so that it's a conversation that we have with every parent and try to initiate in every child at 9 months of age with SS or S beta 0, regardless of the severity of their disease. And why are we so comfortable with this? Why do we push this? Well, the evidence comes really from two studies. The MSH study in 1995, where a study of adults showed that, so basically when you look at the number of events that are happening here, the lower you are on the curve, the lower the curve is, the less events that have happened. So what we see is when you look at patients who are on placebo versus hydroxyurea, on the left side here in adults, you see there was a reduction in the number of events of pain that they had when they were on hydroxyurea. And of course, when we look at kids with Dr. Winfred Wang's study out of St. Jude, 2011, the baby hug study, we call it, we see a decrease in acute chest syndrome in hydroxyurea patients. We see a decrease in pain in hydroxyurea patients. We see a decrease in dactylitis, swelling of the hands and fingers in hydroxyurea, in the fingers of the hands and feet. We see that in the hydroxyurea patients, and we see a reduction in transfusion need in the hydroxyurea patients. This has led to, of course, our stance on hydroxyurea. So when we talk about the new therapies, I want you to keep in mind that this is not necessarily a hydroxyurea or new therapy conversation. Every therapy we talk about is a hydroxyurea and conversation. The preferred situation is that we have a patient who's benefiting from multiple drugs to really amplify their survival and amplify their organ protection. And here, at least in the United States, we have a huge problem with hydroxyurea adherence. My prescription writing rate is probably 90% for the hydroxyurea eligible patients. Of the patients who take it, it's probably 20%, 25% in that range. I hope that in Australia, you guys have a better sort of success outcome, but we have many sort of medical and social reasons behind this, right? So patients sometimes, they drop their counts with hydroxyurea. They have side effects, abdominal pain, hair thinning, skin changes, right? That makes it not tolerable for them. But of course, there's social issues. Why does my nurse put on a glove before she administers hydroxyurea to me? It's going into my body. Can I get pregnant? Is this going to change my sperm count, right? All issues that come up over and over again with hydroxyurea. So there are definitely some issues associated with its use, and our discussions around hydroxyurea have not been, as providers, effective. So let's jump into the first drug, Endari. So Endari is basically L-glutamine. L-glutamine is a conditionally essential amino acid. That means in times of stress, it becomes low. And when red blood cells were studied, particularly in sickle cell patients, it was found that sickle red blood cells take up L-glutamine at almost triple or 4 times the rate as compared to normal red blood cells. And this is really interesting because L-glutamine results in the creation of something called NAD. And NAD is very important, and you might have heard this term, oxidative stress. NAD, or antioxidants, right? So NAD is basically antioxidants. It builds this antioxidant pathway within the body. So the thought was, if we give patients L-glutamine, they make this NAD, NADH, they supplement this system within their body, and they're able to have their own antioxidants. And what was found in a study of 230 patients that took this medication, broke it up into 2 groups, again, placebo and patients who got L-glutamine, of which 2/3 of the patients were on hydroxyurea. It was found that with or without hydroxyurea, L-glutamine was associated with fewer acute pain episodes, fewer hospitalizations, fewer days in the hospital, and fewer acute chest syndrome incidents. And again, this is that same type of graph showing cumulative numbers of pain crisis on the left, showing that L-glutamine patients on the L-glutamine arm had a reduction in the number of pain crises. And then what we see on the right side here is time to the first crisis and time to the second crisis. And we see there's a big difference in basically the amount of time it took for patients to report a first crisis when they were on the clinical trial, and then their second crisis. So L-glutamine showed that it delayed the onset of pain. No significant adverse events reported in the trial. One advantage is that there's no therapeutic drug monitoring required here. There's no checking of levels. There's no checking of CBCs. There's nothing like this. The mild adverse effects that were noted were low-grade nausea, non-cardiac chest pain, fatigue, and musculoskeletal pain. Long-term efficacy at this point is unknown, and ongoing studies will report on that. And again, one thing that's very interesting is though the mechanism that I discussed is theoretical, we really don't have confirmation on the mechanism of action of this drug. All right, let's talk about Oxbryta. So Oxbryta, or voxelotor, is a new oral agent made by a company called Global Blood Therapeutics. And remember, when we go back to sort of this picture here, we talked about the shape of red blood cells being circular and it being dependent on the oxygen coming off of hemoglobin for the shape to change into the sickle shape. Now remember, that's because the hemoglobin S polymer can only be made in states where oxygen has come off of hemoglobin. So Global Blood Therapeutics said, okay, what if we make a medication that allows hemoglobin to hold on to oxygen just a little bit more tightly? What if we keep oxygen on hemoglobin, thereby never allowing the hemoglobin molecule to become sticky and not allowing that hemoglobin molecule to stick to itself and make that polymer, not allowing the sickle cell to form, not allowing for the red blood cell to break open. So they said, we're gonna do that. And we're gonna say our medication is successful if we can increase hemoglobin by 1 gram. And the reason for that was because we have a huge body of evidence that suggests that patients who are more anemic, have more severe disease, are more likely to die, are more likely to have chronic organ damage. Patients who have hemolysis, which is the breaking open of red blood cells, tend to also progress to organ damage and death faster. So what we see in this waterfall plot is in the patients that were treated with the approved dose of voxelotor, almost 60% of them had a hemoglobin response. And we're seeing patients that are hitting 1, 1.5, 2, 3, 4, almost 4 grams of hemoglobin increase on this treatment arm, compared to a 9% response in the placebo arm. So quite an impressive increase in hemoglobin in patients that are being treated. So you may say to me, Dr. Z, 1 gram of hemoglobin, what difference does that make to me? And I'll tell you, 1 gram of hemoglobin for a sickle cell patient is the equivalent of 1 bag of blood. 1 gram of hemoglobin might be the difference between an extra hour or 2 of activity, an extra 500 or 1,000 steps, right? The answer is we don't really know functionally what that means. But what I can tell you is that in the patients that I have treated so far, in my experience here in Detroit, we have had a tremendous experience in not only hemoglobin increase, but reduction in things like the jaundice that patients are having. The number one thing I hear from patients I've started on this medication is, Dr. Z, the yellow in my eyes is gone. And I never realized how important that was to my adolescent and teen population. And that's pushing them to keep taking this medication, because as we decrease the amount of red blood cells breaking open, we reduce the amount of bilirubin, the amount of jaundice, right? So there's clearly an increase in hemoglobin, a decrease in hemolysis. We think, of course, all of this is pending confirmation. We think that this is going to benefit sickle cell disease patients from progressing to organ damage and progressing to death. There were some adverse events, most commonly headache and diarrhea. The most significant adverse event was hypersensitivity or allergic reaction to the medication. But beyond that, really, this seems to be quite a safe drug. Finally, we'll talk about crizanlizumab, which is also known in America as Adakveo, which is a medication built for pain. Of course, the reason that sickle cell patients interact with the healthcare system the most is related to pain. So certainly we need a medication that can help us reduce the amount of pain that requires hospital admissions. With crizanlizumab, what we're talking about here is what I like to call a Velcro inhibitor. Remember, I told you that as blood vessels progressively get more and more damaged, we start seeing this sort of expression of Velcro almost onto blood vessels that allows red blood cells and white blood cells to stick to them, driving that traffic jam of vaso-occlusion. What we have in crizanlizumab is an antibody that binds to that Velcro, that allows it not to bind to other white blood cells and red blood cells and not allow that traffic jam to form. So the way that this medication is given as a once-a-month IV infusion, actually for the first 2 doses, it's 2 weeks apart, and then it's once a month. This drug was approved based on these data that I'm presenting to you today. So looking at high dose, which was the dose that was approved. And I don't know if you can see my mouse. Let me just try to pull that up here for you guys. Okay, can you see my mouse? Yeah, okay, good. So the high dose crizanlizumab arm, we see that compared to placebo, which had a pain crisis per year rate of 3, we see the crizanlizumab approved dose arm had a crisis per year of 1.6. And very interestingly, we actually see there were patients in this arm of the study that had no pain, period. So quite a difference, almost a 50% drop in pain. And we see when we break down patients by how many crises they had, so I would say moderate versus severe, we see huge reductions. So if you look at patients who had 5 to 10 crises in the year before they were given crizanlizumab, you see on average they had this median rate of 5 pain episodes down to 1.97, right? So quite an impressive decrease in pain. Again, time to the first sickle cell crisis, time to the second sickle cell crisis increased by a huge amount of time. Adverse events in this group included arthralgia, which is just pain in the joints, sort of, diarrhea, pruritus or itching, vomiting, and chest pain. This happened in at least 10% of patients. The drug, in my experience, has remained safe for my patients. We have infused this patient on at least, we have infused this drug on at least a dozen patients with no issues and a tremendous reduction in their pain profile. So again, combination therapy, this is a hydroxyurea and discussion. Hopefully we can start combining new therapies as we learn more and more about their safety. And we're pushing for combination therapy to be approved here in the United States. And hopefully you'll see some of this in Australia sometime soon. So we truly are on the next frontier in sickle cell therapy. There are almost 20 drugs still in the pipeline that are coming for sickle cell disease. So this is a historic time. And the way that we behave in this sort of next 5 to 10 years is going to change the way we tell the story of sickle cell disease for the next 50 to 100 years. So we really are in an unprecedented era. It's an era that will allow us to correct the historic marginalization of patients who have been subject to inferior outcomes, unfortunately, at least in the United States, mostly due to their race. There has been no new therapy for sickle cell disease in at least 20 years. Thankfully, we now have a new conversation to have with patients. We have a huge problem with sickle cell providers. There certainly are not enough sickle cell providers in the United States, particularly for our adult patients. And this might be contributing to the reason why our adult patients are dying. But I remain hopeful that as we provide new tools to providers for their sickle cell warriors, we may see that providers become more enthusiastic and more motivated to take care of sickle cell disease. With that being said, there's always more to learn. For me, I have given my patients sort of this resource. This is my podcast. It's called Cheat Codes Sickle Cell Podcast, where we talk about new therapies, old therapies, all of the new scientific literature. We break it down in a patient-friendly way to really allow patients to sort of grasp onto some of these very solid concepts that are required in their understanding of sickle cell disease physiology, because at the end of the day, the best weapon you have against sickle cell disease is knowledge about sickle cell disease. And as long as you have that knowledge of sickle cell disease, it's very difficult for physicians, nurses, things like that, the healthcare system at large to treat you poorly. So I urge you to follow Dr. Z Sickle Cell on Twitter, Instagram. Please subscribe to the podcast. That is all I have for you today, Agnes. I hope that that was helpful to the patients who are listening. and I appreciate you giving me this platform to interact with our Australian warriors.
That was very, very helpful. And I think we'll go to Dr. Von Shah to quickly introduce yourself, and we have questions.
Okay, sure. I think you're still sharing the screen though. Maybe could we get rid of the screen sharing? So hello everyone. My name's Shao. I'm a scientific advisor with ASCA. I have a background in globin gene regulation and thalassemia, less on sickle cell anemia, but hopefully I can still contribute to the conversation. So thank you so much for that talk. That was really excellent. I really enjoyed that. I just had a couple of questions with regards to maybe the trials and the costs involved. So firstly, the responses to the drugs that you showed, were those all already in combination with hydroxyurea?
Yeah, so that's a great question. Thank you for that. Basically, every trial that I showed you had approximately 2/3 of the patients on hydroxyurea across the board, in both arms, placebo and drug. And that's true for Endari or L-glutamine, voxelotor, and crizanlizumab.
Right. So just in terms of the potential availability of these drugs into the future, I mean, what is the price, the approximate cost for each of those agents? Because it seems like they would be very different.
Yeah. So that's a good question. I can, I'm certain that the pricing points between the United States and Australia will probably be quite different. But in general terms, I can tell you that out of the 3 drugs that we talked about today, Endari is the drug that is the lowest costing medication. In the United States, it costs the insurance company approximately somewhere between $30,000 and $40,000 annually. The other 2 medications, crizanlizumab and voxelotor, are both basically the same price, and definitely a little bit higher cost. In the United States, it costs the insurance company approximately almost $100,000 annually. What those price points will be in Australia, how that works, is probably going to look quite different in a healthcare system that is far more advanced than the healthcare system we have in the United States. So I'm hopeful that for you guys, there will be some cost reduction and a little bit more thought into how to disseminate these drugs.
So just one more question. I was just wondering with the L-glutamine drug, which I can't remember the name of the label.
Yeah, sure.
With the L-glutamine, has that ever been trialed in other conditions? Like, do they have any clinical data about long-term effects or medium-term effects for other conditions?
That's a really good question. I think that the specific formulation, that company themselves, are looking at its use in diverticulosis, but those data are emerging. I think at large, L-glutamine, one study that gets cited quite a bit is the use of L-glutamine in multi-organ failure in very sick patients where it didn't help. So there's not much as far as L-glutamine helping other conditions at this point in time. I certainly know that the data surrounding diverticulosis, which is an intestinal condition, are sort of emerging at this point in time.
Great, that's all I have for now.
Thank you, Dr. Shao.
Isabel, you're mute.
There you go. Yeah. I had a question for you too, about the L-glutamine. Was it actually given in powder form, or was it infused?
Great, that's an excellent question. It is given in powder form twice a day.
Okay.
And it's dosed by weight.
Okay.
Natalie, do you want to dive in?
That was an excellent talk. Really enjoyed that. But I think a lot of the questions that I was thinking, Shao really covered them quite well. And so with the other drugs, though, I am interested to know, was that also available to children or just adults?
Sorry, which drug?
So voxelotor and the other
Voxelotor,
one,
yeah,
yes,
sure.
yeah. And
Sure, that's a good, yeah, you're absolutely right. We didn't cover that. That's a mistake on my part. So age-wise, at least for now, the FDA has approved Endari, which is L-glutamine, from 5 years of age and higher. Voxelotor has been approved from 12 years of age and higher. And crizanlizumab has been approved from 16 years of age and higher.
Okay.
All of these companies are working to expand the age group that they're allowed to give this medication to. In fact, voxelotor is doing its confirmatory trial on the transcranial Doppler. So they are looking to see if voxelotor will reduce the velocities in the transcranial Doppler. So they're hoping to drop their age indication into as low as 2 years old.
Okay. And one other question that I also have is that, so if we look at hydroxyurea, clinical trials, studies and results went on for quite a long period, and these newer drugs have been introduced, this soon. So how much time do you expect that observations will still carry on for? Because it seems quite optimistic so far, but...
That's an excellent point. And that point comes up frequently, even amongst the physician provider community, is should we wait? Do we wait for outcomes data? Do we see what happens over the span of, 5 years, 10 years? And there's really two schools of thought there. For me, I think that we have made the sickle cell provider community, we have made the sickle cell patient community wait too long for new therapies.
Definitely.
And I think it's personally for me a choice that I'm making, that I want to offer new therapies to my patients without a tremendous amount of outcomes data, because I feel like these medications at the very least are safe. I actually think they're effective, but I can certainly tell you I know they're safe. In that context, I think we put our patients in a high sort of a high reward, low risk type of situation, where there may be, I don't want to wait 5 years for outcomes data and be 5 years behind on my sickle cell patient that has now had 5 years of progressive organ damage. I think for us to get to the point of hydroxyurea, it'll probably take us almost 5 years to a decade. So I think that we need to balance, our risk and reward here.
Dr. Z, we have a question from our Facebook page where they're asking, what are the side effects on the new drugs?
Yeah, so we covered a few of them, but essentially with Endari, what we see is, and I'll talk, not so much from what was published, I'll talk about my clinical experience so far. From Endari, what I've seen has been a little bit of abdominal pain, a little bit of nausea. We've seen some diarrhea, nothing that has resulted in patients stopping the medication from Endari. On an Oxbryta standpoint, the common one seems to be, again, diarrhea, abdominal pain, rash. I have seen all three of those. None of my patients have stopped the medication for any of those side effects, but certainly the diarrhea issue does come up pretty frequently. From a crizanlizumab standpoint, the biggest side effect we worry about is reaction while the medication is going in, right? While you're getting that IV infusion. I haven't seen that yet. We've infused the product at least 10 times at our institution, and we have not had one of those reactions. The side effect profile associated with Adakveo that was published were things like itching and arthralgia and pyrexia, which is fever. We haven't had the we haven't been able to see any of those actually at this point in time. It seems like it's pretty well tolerated.
Can I ask also then, were those trials based only on the use of, say, hydroxyurea and Andari or the voxelotor? How were they reacting with different drugs, like maybe perhaps chelators that some of the patients might have been using? And
yeah, so that's also, that's an excellent question. So the patients that were selected for these trials were patients that were not being transfused.
okay.
So, so the majority of patients that were studied were not on chelation therapy.
Okay.
From a drug interaction standpoint, the only sort of big interaction comes from voxelotor.
Okay.
And it's a very specific way that voxelotor metabolizes. We have this metabolism pathway called P450. And there's a specific part within P450 that voxelotor uses. If voxelotor is used with other drugs that use the same metabolic system,
Okay.
then you may need to adjust the doses. That situation comes up rarely in sickle cell disease patients, but it's something for physicians to be aware of. But overall, it doesn't seem like there's any adverse reactions, contraindications to other commonly used sickle cell medications. That includes opioids, that includes, Motrin or ibuprofen, acetaminophen, things like this.
And just one other question with regards to hydroxyurea. Over the long term, have you seen that how can I say it? Does the effectiveness of it decrease or does it remain the same? I mean, I know that that one is also dependent on physiological change on the patient.
That's a great
Can you
question.
talk about that?
Absolutely, yeah. So I think anecdotally, most of the sickle cell providers you talk to will tell you that there certainly are patients where hydroxyurea sort of appears less efficacious as patients get older. That certainly seems to be the case. What the science is behind that is not entirely clear, but we do see that, which is why these new therapies are so necessary at this point in time, because as we do have patients that lose that hydroxyurea effect, we're going to need to find other ways to offer them some protection against their disease. So yes, you're absolutely correct in that point.
And sorry, one other question that I also had. So over the long term as well, for patients that, for example, have taken hydroxyurea from a young age right into adulthood, have you come across those patients? What generally could you say might be the quality of life? Do they still benefit? I mean, if you have to measure in your patients, what are the percentages, if you can call it that?
It's hard to say. So my medical experience is limited to the pediatric population. I'm a pediatric hematologist, so I get to see them while kind of things are all hunky-dory, right? So I get to see them while the hydroxyurea is working and everything is good. They haven't had any of their major complications. Quality of life while patients are on hydroxyurea, who are tolerating it well, who are responding nicely, their quality of life is tremendous. I mean, they are really limited in the ways that sickle cell disease is affecting them day to day. That's been my experience with patients who are on maximum tolerated doses of hydroxyurea. That's also the experience of, for example, recently we had what was called the REACH trial that was published out of sub-Saharan Africa in 4 sub-Saharan African countries looking at the use of hydroxyurea. Very similar story coming out of there. That the quality of life was tremendously improved. That does start to deteriorate potentially once you hit adulthood, probably for a variety of reasons. I can't give you specific percentages offhand, but I'm gonna think on that a little bit, and I'll get back with you, Natalie. And
with the reasons, is that due to non-adherence, non-compliance, or
it's probably a combination. It's probably a combination of changing physiology a marrow that is becoming a bone marrow, you know, the sort of the production site of blood that's getting a little bit older, that's getting a little more tired, and maybe a little bit of non-adherence, non-compliance thrown into that as well. Perhaps as you get older, the side effect profiles change slightly, but it's definitely a combination of both sort of environment and physiology.
Okay. I'm mindful of time, but I've only got one question. I think most of the questions have been answered, and maybe you may have mentioned this before. At what point, when you start giving these medications, do you think that maybe you've got so much side effects and you might stop? How do you, I don't know whether you covered that before.
So at what point do I say enough with this medication? You know, that's a great question. I really kind of, I like to empower the patient to make that choice. I certainly, you know, for things like hydroxyurea, there's some black and whiteness to that, right? So with hydroxyurea, your neutrophil count is too low, your platelet count is too low. It's clear. I'm going to stop this medication. With some of these, so for example, the patients that I had with voxelotor, she said, you know what, I'm having diarrhea, but I like the way the medication's making me feel. I like that the yellow in my eyes is gone. I feel more energetic. I think I want to stay on it. I can deal with the diarrhea, right? So in those types of situations, I think the patients are better equipped to make a decision whether this is interfering with their quality of life as a side effect, or if it's tolerable compared to the benefit that they're receiving. You know, I specifically, from a medical standpoint, really it would have to be a side effect that's putting the patient's life in danger that makes me want to say enough. So for something like voxelotor, it would be a rash, allergic reaction that is very severe. For something like Endari, it might be, you know, abdominal discomfort. For something like crizanlizumab, it might be reaction to an infusion that went in. So each drug has its own sort of red flag or, you know, warning sign.
One more, then we're done. So with the people who are affected, they haven't started these drugs yet. How do they decide? Do they just go to the GP and say, look, I've tried hydroxyurea, can you try this? Or how do you know, like, what the right patients to try these medications?
Yeah, so I think that every patient, every family should be doing their sort of research on all of these new therapies. I think that reading about it, following the sickle cell community online and seeing what people are saying about it is very important. I didn't get a chance to look up the approval status of these medications in Australia at this point in time. And I don't know if you guys have access to these medications yet or not.
Not yet.
Hopefully soon.
Except hydroxyurea, sorry.
Of course. Yeah. So I hope that, I really hope that, you know, patients at least, you know, the modern patient is a lot more informed these days. So I'm definitely having patients coming to me saying, hey, I heard about this medication. What do you think about it? And I think that that's the best way to go about it. Having these conversations with your doctor upfront, making sure that you are aware of what's ongoing, following these companies online, following other sickle cell physicians online is a good start to sort of making sure you're ready to go once these medications become available in Australia.
Sorry, so there's just one question on the Facebook page. Maybe Isabella can do it.
Oh, okay. Well, I've just been waiting for everyone to have their questions answered. There is one from Junior, and they've asked, how long do you think it would take for the new drugs to be available in patients, for patients in Africa?
Wow, so that's a good question. I know personally from speaking to basically all the companies that they are very invested in getting these medications to Africa. I'm going to throw a guess out there. I'm going to say maybe 5 years before we
85.
start. 5
Okay.
years.
My old people's years aren't working that well. 85.
Yeah.
Maybe
yeah.
5 years before we
Sure.
start seeing the first sort of experiments
Okay.
or clinical trials, I should say.
But then, Indaria has been around since 2017. I don't think we have it that much in Africa as well.
Yeah.
So 17, probably it's only 3 years.
Yeah.
So.
Yeah. So I
Yeah.
mean, yeah, that's true. That's true. I mean, Andari is still working pretty hard to make sure they get the drug out in the 5%. They still haven't even hit all the 5% countries.
Okay.
But
we should call out Dr. Utata. Is it Utata? The CEO for.
I'm sure he would be happy to talk to you, Agnes.
Yes. Yeah. Natalie, Isabel, Shao, do we have any questions before we give our guests the last word? Because we're out of time.
No, none from me. Thank you very much. This was a really good session.
Thank you,
very
Natalie.
Yeah,
informative.
thank you.
Yeah.
There's a lot of compliments on the Facebook page too.
Yeah. There
Thank
sure
you.
is.
Thank
Yeah,
you.
there sure is.
You really cut through the scientific stuff.
Thank you.
Yeah, so that was good.
Thank you. I appreciate it.
Okay, well, just a big thank you again. Thank you for accepting our invitation. Like I was even telling our members that, I've been following you on social media and I just like how passionate you are about sickle cell, people affected by sickle cell. You call it as it is, and I love that about you. So
thank you.
I will share all your Twitter handles, all your social media platforms, and also your podcast. I have shared a few podcasts on our closed WhatsApp groups. So I just want to thank you again. Thank you, Isabel, Shao, and Natalie. And these sessions, because they're recorded on Facebook, they'll be running over and over again. If people watching this, they still have questions, you can send us questions and we're going to forward them to Dr. Zaid. And you can email them to info@allsicklecelladvocacy.org or just send them to the Facebook page. And so for us, these sessions will continue. Our next session is next Friday. I don't know what you're doing next Friday for. About sickle cell dead, Dr. Zaid. You've got a 2-hour session with different panels. So I won't share because we're mindful of time. I won't share the slide I was supposed to share because that's the main session next week, Friday. So we just want to thank you again for joining us, and hopefully you can join us again.
Thank you for having me. Take care, everybody.
Okay.
Stay safe.
Thanks, you too. Hope to see you
Bye-bye.
soon.
Thank you.
Bye.
Bye.
Thanks. Bye.